for organizing this incredibly exciting symposium. I don't know whether it's the pressing of the CV26, it's the military, or just the content. I only had 3 hours sleep the night before, only 5 hours traveling from the United States. I was going to take a nap, but I've been just awake and paying attention, taking notes. So hopefully I will do the same to you guys. So my talk is evidence-informed acupuncture in cancer care. So I have no conflict of interest except for getting grants from the federal government. And just for those of you who don't know about Memorial Sloan Kettering Cancer Center, it's founded in 1884 as the first cancer center in probably the world, and it was called New York Cancer Hospital. It's the largest and the oldest private cancer center, and one of the very first National Cancer Institute designated comprehensive cancer center, started from 1971. At MSK, we do not only just treat cancer patients, it is a place many of the conventional cancer treatments are developed and tested. So we have anytime ongoing of 550 clinical trials for cancer patients and for both adult and pediatric patients. So when you work in the context of this large cancer center, so our job in integrated medicine not just be a service providing care, we also need to be on par doing cutting-edge research that change the way how integrated medicine is delivered, including acupuncture. So our service was established in 1999. So over the years, we have contributed a number of literature to the area of oncology acupuncture. And today, in the interest of time, because I was asking for an hour from Claudia, she only gave me 20 minutes. So I will just focus on one specific symptom. So anyway, I was sorry, that's just a joke. Everybody got 20 minutes. So evidence-based medicine is a field also developed in the 1980s, really integrates the best available research evidence combined with clinical experience and patients' preference, values, and rights. So I taught evidence-based medicine at University of Pennsylvania Medical School, and often for the people who are naive to EBM, they just thought evidence-based medicine is just research, it's just a p-value, it's just significant or not. Really, it's not. It's much more nuanced. Really, we need to really consider all three aspects. So for the rest of the talk, I want to show you how we can apply this framework to acupuncture as we develop this field. So as we know, pain is a very common symptom in patients with cancer. It really permeates through the entire cancer continuum from active treatment, survivorship, to palliative care. And pain is complex. It's not only originated from cancer, many of the cancer treatment can cause pain, as well as the psychosocial context of the individual can make the pain experience more intolerable and persistent. So especially in terms of the treatment of cancers, there's not a single cancer treatment that does not cause pain or symptom distress in patients. So area of research focus I've been focusing over the years is hormonal treatment in women with breast cancer. So earlier, I think Vitaly mentioned 15 years. I think that is a magic number. I started my research career in 2013. And I do think I finally feel like I'm in a stage of research. I have actual data to present. Unlike Claudia, I think actually started her career very early. And I just feel like, I don't know how she does it. She doesn't sleep. I know that. No, I don't, but that's my hypothesis. And so this is a patient. I just became assistant professor at UPenn. I saw 61-year-old with a stage 2 estrogen receptor positive breast cancer. She finished chemotherapy. She was put on this drug called aromatase inhibitors. In the US, it's called Arimidex. After about 6 months, she developed this diffuse pain every joint, especially in her elbows and shoulders. Here's her words: my body just aches and aches. I'm only 61-year-old, but I feel like I'm being trapped in an 80-year-old body. I love play tennis. I cannot do it anymore. I really wonder I should stop this drug. And this is a cancer-saving drug. If she stops it, she will risk the chance of increased recurrence and increased overall mortality from it. So here is a women have to weigh quality of life against survival benefit. And at that time, there's actually the trial that Claudia published in Lancet, and there's a Brian Berman published on osteoarthritis pain with acupuncture. Beyond that, there's not much evidence for acupuncture for joint aches in women with breast cancer. But I treated her based on those principles, and she had an amazing response. And as a result, I developed the last 10 years with a research focus on understanding the symptom experience of this, as well as developing acupuncture as an intervention. So we're funded by American Cancer Society to do an epidemiology study, found 1 in 2 women on this drug experience side effects related to aromatase inhibitors called joint pain or arthralgia. And then we use a genetic epidemiology approach to show that genes regulating the aromatase genes synthesize are basically preventing the conversion from testosterone to estrogen is associated with the symptom, suggesting biological hormone deprivation process is related to this symptom. And recently we published a paper showing that fatigue, pain, insomnia are often happen in these patients together. So if you look at fatigue, is the biggest circle, and then with clinically important pain and clinically important insomnia being smaller circle. But with that said, if you have either insomnia or pain, 97% time you also have fatigue. So I know Rick probably later on is going to talk a little bit about fatigue. So as we see these people in clinical context, we just don't necessarily see one problem, we see a series of problems. Now how do we develop interventions is, it also shows you probably one size fits all is not the best approach. There's probably population we really need to target fatigue only. There's a population we need to target both pain and fatigue, and there's probably we need to target all 3 of them together. And we also show when those symptoms clustering together, they're associated with a general increased inflammatory biomarkers such as CRP, Otaxin, MCP1, and vitamin D binding protein. Suggests inflammatory response is potentially part of the biological pathway for the shared mechanism for those symptoms. And also importantly, we found that a lot of women's decreased physical activity instead of moving more after breast cancer, which can be very detrimental for their overall health. So, but for those patients experiencing pain, 62% saying they have to reduce their physical activities, and 38% and for those people without the symptoms. So this is really the egg versus chicken question. Like we have those exercise scientists with whom I love and I collaborate a lot. Exercise is great for pain, but only if you can exercise, right? So I think that's where acupuncture can play a role to help people control the symptoms, get them moving again. And I'm also I'm a medical doctor, but I think secretly I want to be a psychologist. So when I talk to the patient, when they complain about I'm aging, I feel I'm an old woman, I age a lot. So I actually worked with our psychologist colleagues at UPenn, developed this Penn Arthralgia aging skill, measure the perception of speed of aging as related to joint pain. So what we actually shown that this skill can predict people swapping the life-saving drug aromatase inhibitors. So when you have this sort of variable entered into a multivariate model, is sort of a 70% of increased likelihood to stopping the drug. And also when you put this variable into the model, the association between pain and stopping sort of went away, suggesting it's not just the pain, it's how you psychologically make your mind about this pain. You know, this pain makes me feel old. This pain makes me feel horrible. And I have to stop this pain, right? So there are probably women have the same amount of pain that say, here's the pain, but I need to do something about it. I have to get rid of the pain rather than having this sort of a negative psychological appraisal. So that's why when we are doing integrated medicine research, we have to think about the complexity of what pain really means and to collaborate with our colleagues with a house psychology background to really do it right. And then depression is also another independent variable associated with that. So you're wondering, come on, I'm inviting you for an acupuncture talk. Why do you talk about all this? But this is important because we need to see acupuncture in the broader scope of medical management by only understanding what patients go through, how the symptoms affecting their adherence to conventional treatment. We can creating the narrative why integrated medicine is so important. So let's look at the research evidence. Again, not to blame Claudia, I don't have time to present my own research, but there is a great article just published 2 months ago in JAMA. It's the largest trial done by colleague Hirschman et al., randomized 226 women with breast cancer with aromatase inhibitor associated arthralgia, true acupuncture, sham, and weightless control. The treatment was twice a week for 6 weeks, then once a week for 6 weeks for maintenance or stabilizing. Then people were followed for 52 weeks. The primary endpoint is a week 6 BPI worst pain score. And 2-point reduction defined as clinically meaningful. So I love the whole paper. It's really well done. You should really read it. But I really didn't like the conclusion that much. The conclusion was we found a statistically significant reduction in joint pain at 6 weeks for true acupuncture versus sham or weightless control. However, the difference was of uncertain clinical benefit. So I just read similar trials published on duloxetine, a drug, and exercise trial compared with nothing. Those conclusions are definitive, they're better. But if you look at the difference between real and sham for the drug, was 0.87 point, was actually less than the difference between real and sham acupuncture. So I'm an epidemiologist, so I want to just leave this for you to think, is there bias in publication? Is it for you to judge? I won't make the point. But what I did make the point is I wrote a letter to JAMA, and they're considering publish, but they haven't told me the final answer. So, but you know how JAMA, until they publish, they say, we're considering, but we don't know yet. So basically, what we use their defined criteria, which is a well-recognized in the pain field, is a 2-point or greater reduction in worst pain. So 58% of the true acupuncture group are responders versus 33%, 31%. So if you calculate the number need to treat, so that's a number we use a lot in teaching about clinical importance or relevance, it's about 1 in 5 people. And for a lot of you who are not in the field of medicine may think, oh, 1 in 5, that's really nothing. But rarely anything in medicine has a number need to treat is 5. Because like if you look at conventional surgical techniques or other thing, so I would challenge the notion is that this is probably not a non-important effect, it's actually clinically relevant. But then last but not least, let's look at the patient's perspective. So this is a study I did using qualitative research technique to really elicit patients' preference and decision-making about acupuncture in the context of drug use for pain management. So what you can see is a lot of women come to the decision of acupuncture. It's not necessarily they fully embrace acupuncture, it's really they want to try something more natural. Because they feel like their body has been brutalized by a lot of conventional cancer treatment. For the symptom management part, they want something more natural. And I don't know about in Swiss, in the US, there's a big pharmaceutical industry. For everything, there's a drug. So a lot of time, by the time patients in their 60s, they are on a lot of drugs for blood pressure, for diabetes, for hyperlipidemia, for all kinds of things. So a lot of the comments I get is, I'm taking enough medications, I just want something more natural. So this year we have done a cross-sectional survey study in women with breast cancer experiencing pain. We actually found that when you present options of drug versus medication, about 27% of them will only prefer acupuncture, 26% only prefer drugs, and 47% have no clear preference. And the higher education and white race are associated with greater preference for acupuncture. In general, these two variables are important social demographic variables in U.S. context, meaning higher socioeconomic class. However, if you add health beliefs such as expectation barriers into the model, you really attenuate that association, meaning it's not just the race or the education, the socioeconomic level, it's actually those health beliefs. And what are they? Higher expectation related to acupuncture, greater endorsement of acupuncture from families and friends, holistic health beliefs, and lower perceived barriers such as having access, having money, having time. And so we clearly have demonstrated specific attitudes, beliefs can predict utilization preference. So the next step is how do we develop health systems that are accessible and equitable for all diverse cancer survivors. So as of today, National Comprehensive Cancer Network recommend acupuncture for adult cancer pain, cancer-related fatigue, nausea, vomiting, using palliative care context and survivorship. And so this is a national guideline committee for cancer therapeutics. So I would say there is enough evidence to consider acupuncture as a broader scope of supportive care. And we can really apply the principles of clinical experience, incorporate patient preference and values, and combine it with research evidence as we make individual decisions as well as advance oncology acupuncture. And as MSK, I think our next step is trying to really train more acupuncturists and provide oncology acupuncture, because oncology patients are inherently more complex, both medically and psychosocially. And a lot of the acupuncturists in the US are non-physicians. They receive very little training in what oncology drugs or other type of safety information related to oncology. So there's clearly a need for better education. So today we have trained about 400 oncology acupuncturists in this basic course curriculum. And in the US cancer centers, there is a robust growth of the integrative oncology program. So this is a study, we did a study in 2009, we did a study in 2016. We found that there's a 30% increase in recommending acupuncture and as well as other complementary modalities for symptom management in the website of comprehensive cancer centers. And the provision of acupuncture in large academic cancer centers is about 75%. So I want to invite all of you to visit New York next October. And we're located 10 minutes from Central Park if you want the sedating effect, and 10 minutes away from Times Square if you want the stimulating effect. So we're really wanting you to come twice to the United States. In June to Vermont. It's beautiful, and I can attest, I'm not from there, but I love Vermont. And then for the calming effect in Vermont, and October to New York for stimulating effect. So thank you very much.